we are planning now to launch a virtual course in Essentials of Pediatric Palliative Care Nursing in Oncology. That will be a similar 9 weeks course. And you can already start to warm up your nurses so that when we are ready to launch it, many of them can join it. And then maybe, Archana, would you like to tell us about the workshops?
Yes. So the nursing course that we have planned, it is for all nurses. Whoever wants to join, we have not kept any minimum number because it's a virtual course. And thereafter, we also plan a in-person workshop in Hyderabad after the virtual course, wherein you can nominate few nurses whom you feel would be interested and would be capable of heading the pediatric palliative care nursing in your hospital. So for that, we'll do it in person, and we have also decided to host scholarships for the nurses for travel and stay in Hyderabad. So we are planning 2 workshops, one in Hyderabad and one in Mumbai. So first we'll go into the virtual workshop. We'll send the flyer soon. And then after that, we'll have the in-person workshop. The first will be in Hyderabad. It will be a 2-day workshop. So we have planned teaching sessions on one day and hands-on experience on the second day. So it will be a 2-day workshop. We'll all let you know more about it, but please sensitize your nurses and encourage them to register first for the virtual platform. Thank you.
Right. And thank you. And now it is my pleasure to introduce Vinuta Suresh, who is a psychologist in the Department of Palliative Medicine at Cancer Institute Adyar in Chennai. And she's going to give the session, I think, on her own, if I understand. No, is that so? Because only one of our faculty is present today.
Veronique, we have she'll be leading the session, but we also have Dr. Arjun and Vinila who will be moderating the case discussions. Because sorry about this, in the last minute, because of the ongoing war, there were some changes, and one of the faculty from Gulf could not join the session today. So,
if I may just interject here, Dr. Arjun is a specialist consultant in palliative care, and he will be joining us today to participate in the case-based discussion, which Vinita will be leading, but they will also be contributing based on the practical experience. So just a quick one more thing. I think Dr. Ramandeep has joined. Dr. Ramandeep, maybe you would like to just address today being a last day of the session, would like to just address the gathering.
That's very kind of you, Gayatri. I'm sorry, I'm in a flight, just landed. So give me some time. I'll, switch on my camera and speak more clearly later. Please carry on.
Yeah, just do let us know when you're ready. Vinila will be helping you to facilitate. Yeah, thank you.
So, Vinila, can I start now?
Yes, ma'am.
Yeah, very good evening to all of you who has joined here. So today we are going to talk about grief and bereavement in pediatric palliative care. As you all know, you would have learned a lot in the past weeks. But the loss of the child at any age is indeed a profound, difficult, and a painful experience. And not much of it is talk about it is happening in our wards. Though the grief of the loss of a child is the most intense form of grief. So today we'll be talking more about it, not only about the grief, how to identify the grief red flags in the families, the caregivers, and also the oncologist who care for the pediatrics also experience intense grief when the treating child dies. So we are also going to see a bit of how to manage those situations. So this is going to be today's session. So we are not going to talk more about any theoretical aspects or lectures. We are not going to talk more about Western perspectives. And we are, of course, you're oncologist. We are not going to convert you into therapist. There are separate psycho-oncologists for that. And finally, I'm not going to talk about grief and bereavement of families. We are going to talk about the grief and the distress and the burnout experienced by you clinicians who are treating them. So by the end of the session, you should be able to know what is grief, what is bereavement, what are all the red flags that we can identify in the anticipatory grief stage of from the families. How do you handle it? What do you say? What we are not supposed to say? Whom do you refer when you find red flags? So these are the things that we'll be talking about today. What is the difference between a normal grief? What is a prolonged grief? We are also going to see how we are going to make bereavement follow up. And of course, as I told, we are going to talk a bit about self-care. So first, understanding grief in pediatric oncology. We'll take a case and we'll talk about this particular case throughout this session. Okay. Yeah. This is a case of a 6-year-old boy with a relapsed ALL. And after multiple lines of therapy, the family had opted for comfort care, after which the child died with minimum symptoms at home. So 2 weeks later, the mother calls up and says that she is able to see the child every day in her dreams. She's not sure whether it is dream or reality, kind of mix, and she always feels that he's constantly crying. And she has this feeling of guilt. Did I kill him? Have I done enough for my child? I'm feeling guilty. So I hope all of us would have come across a similar situation in our practice. I would just want you to post it in the chat. Whatever the mother is experiencing, the mother of Ravi, is it a normal grief? After 2 weeks of the death of the child, is it normal? Or any similar cases you would have identified or in your practice? So, what do you think about it? Have you come across any such cases? Yes, then you tell me whether it is a normal grief or you identify any red flags. You can just post it in the chat. So, based on your feedback and discuss, only we can take this forward. Okay. Could see any answers, Vinila? It's been only 2 weeks. I think she's taking time to adapt and cope. Perfect. Thank you for your answer. Yes. So it is just 2 weeks, and this is a normal grief reaction, and the mother is trying to adapt, and she is seeing the child in her dream, which is of course normal. And as a treating oncologist, whoever receives the call, what will be your immediate reaction? How will you respond to this call? So I would just say that if you have any suggestions or any answers, you might as well post it in the chat, which I'm constantly monitoring through during the session. What we can do is, instead of getting into a defensive mode or starting into advising mode, yeah, perfect, listening to her. All she needs is somebody to listen and validate her emotions. Whatever is she's going through right now, it is a normal feeling, and we have to offer correct, perfect. Listen to her and ask her more about the dream. Yes, of course, you can ask her to elaborate, be there for her, listen to her, because of course this is not going to happen in her family setup, where grief and bereavement, I have to say, it's very, very specific, cultural specific context. Every family grieve in a different way. There are few families which say that it is not good to talk about the deceased ones. So there will be always shunning of not talking about the deceased. So we allow her to talk. So that is the first thing that we have to do. Encourage her to talk more and explain her that this is a normal thing that happens to most parents, and just tell her whatever she has done is more than enough, and we had done our best for the child. So this is not going to she's not going to get over this guilt in 1 or 2 conversation or 1 or 2 months. It's going to continue, but every time we have to be there for her, instead of providing advice or becoming defensive or getting offended or explaining her the treatment that we provided, and all those things are not required at this time. Now, as we discussed now, intense grief in 2 weeks post death is it considered normal? You think we already discussed that it is absolutely normal. When should formal bereavement support ideally begin? Can you tell me, any of you? You can as well unmute and say if you want, or just post it in the chat. When should the bereavement support should begin? Whether it is before death, after death, at the time of death, all the above. 3 months after death is what I see. First contact is what I see. Please keep coming. Yeah. When should formal bereavement support from the healthcare provider or the hospital team should begin? It has to begin even before the death of the child. Okay, so it is not at the time of death, at that after the funeral. It is even before the death. It is the time we start preparing the family about what to expect, what might go wrong. So these are the disease trajectory. We have to just prepare the family, and this is called as, and during their anticipatory grief, about which we are going to talk more in the coming slides. Yeah, ideally it has to begin before the death. Are the stages of grief, as we all know, DABDA, is it a linear process? No, people, it is not like a straightforward linear process. And we cannot tell them that, no, you are in a denial phase. How can you be in acceptance phase first? So nothing like that. Some people will accept initially after the death, but slowly after the grief sinks in, they'll go to depression, they'll go to denial. So it is just like zigzag. It will be not in a linear order. So now let me come back to what is the classic definition of grief, bereavement, and mourning. So grief is, we sometimes use these terms, interchange these terms and use, but we have a classic definition for that. Grief is a process. Basically, it is how your mind reacts, emotions, how your body reacts, physiological, psychological, social reactions towards a loss of someone or something that you love. Grief can also be for losing your loved one, or loss of a job, or during a breakup, loss of a pet. It can happen anytime. Okay, it is a psychological response, physiological response when you encounter a loss. But bereavement is actually a state after the loss. Okay, it's a period after the grief, a period or a situation that you encounter or having experienced a significant loss. That period or a state is called as a bereavement. Mourning, of course, it's a cultural expression. It differs from country to country, religion to religion, region to region. It is how the society looks at the grief, how the society handles, and what we do after a grief. So it is called as mourning, the action or a behavior of a after the loss. So whenever you have a doubt or you think that I'm not clear, you can always post it in the chat. I can repeat that for you. So what makes bereavement, pediatric bereavement or pediatric grief very, very is special? When I say special, it is considered to be the most intense form of grief. Why are we discussing that in a special session today? Because it's a violation of natural order in first place. So we expect the children outlive the parents in any context, and the parents never expect their child to die before them. So it's absolutely it's not a natural order that triggers intense guilt among the parents or the family member to be even alive when the child has passed on. Did I do enough for my child? Should I have done something differently? So there is an intense guilt, intense feeling of why should I even live now? So there is absolutely lack of meaning in my life. So that is called as that makes pediatric grief very, very different. So there are also secondary losses. When I say secondary losses, till now there will be a lot of a caregiving duty that they have. They'll be having an identity as a parent of a cancer patient. They'll be having the entire community, family, extended family supporting them. Now everything is totally disrupted, and now they will have a sense of voidness. What am I going to do now? So that sense of voidness will be there, and health risk. When I say health risk, there will be lot of depression and anxiety which cannot be shared to anybody. That is very specific to our cultural context. We expect only to grieve amongst the family members. There is still lot of resistance to talk about what they go through in the extended family, they feel like a failure after having lost a child, and they don't want to talk about it or accept any help from the extended family. They feel that their feelings are being totally dismissed, or even in a situation or any family function, they are not invited in some families, or even if invited, they resist going to such places. So these kind of stigma are there, and reaching out to a professionals like psychologist for counseling is still, India is still not there. So that kind of evolution hasn't happened here. So a lot of suppression leads to health related complications, and needless to say about resorting to any maladaptive coping among the family in our context, especially in Indian and lower socioeconomic context. Financial toxicity, they would have lost their entire savings for the treatment of the child, and loss of income, because most of the families, due to caregiving responsibilities, they'll not be able to have a continued job. So all these factors, and these are some of the factors that I have mentioned. There are a lot of other factors also adding on to the unique challenges of why pediatric grief is very very intense and very very different, and why it needs to be handled very specially. So the picture here is a bereavement support program that is happening, that happened in our Cancer Institute Adayar. This is actually very very unique. When I say very very unique, in India it's a collectivistic country where grief is a very individualized experience. It is only we grieve in a close circle, we grieve within the family, and we don't get any help from anybody. We resort to karma, we have spiritual beliefs, we think I deserve this, and all these kinds of things are there, which shapes our bereavement and grief. So somebody attending a bereavement support program offered by an external people itself is very very special. They don't take help from strangers, especially from the treating hospital. Why do you think that accepting support for bereavement in the grief journey from the hospital management where the child got treated is not possible or very, very rare? Why do you think so? Do you have any answers? There will be a lot of anger. Of course, there'll be a lot of anger amongst the families with the hospital and also the treating doctors, isn't it? So you have been treating the child for years together, months together, but the child is not there anymore. There will be intense feeling of anger, and they don't want to visit the hospital anymore. They are going to relive the trauma. So they don't want to visit the hospital. So of course, these are the things that makes providing support for the grieving families is very very challenging, and it is very very culture specific. And also we have gender specific grieving in the family. Mother always have a feeling of whether I looked after him well. I am eating well now. He hasn't had any food during his last days. So those self blaming will be there. And in India, the male is not supposed to express the grief or cry in public. So he's expressed to be a father's choice and should be there. He should be strong. And these are the things that prevent the father. He's taking away his right to grieve in the way he wants to grieve. As I told you, there is like illness is viewed as a karma. What have I done wrong? Why did my child pass? Did I do something wrong? So these are all the things that will come into their mind. Next one is sibling. So sibling are considered to be hidden patient, isn't it? Most of the time that we see children, sibling will be left at home, left with somebody else, and only the parents come to the hospital. They are totally clueless about what is happening. Even the diagnosis hidden from them, and we expect them to be on their own. We don't post them about the updates that are happening. We don't address the fear that the child or the sibling has. So these are all the challenges in during the bereavement period. When a grief happens, these are all the challenges that might happen. As I told you, the bereavement and the grief journey starts even before the death of the child, and When do you think this anticipatory grief stages starts? When the family knows that something is going to happen, when they have accepted that it's not a good prognosis, especially in a relapsed leukemia, refractory solid tumors, when they see that there is a multiple hospital admissions, frequent emergency visits, very pain symptom control is not great, and the transition to palliative care for supportive care. These are the moments that they feel that there is lot of uncertainty, and we can see that the family is in anticipatory stage. They don't know, families, they don't know that they are in anticipatory grief stage because they don't know all these technical terms, but we could see that. So they'll come to the dabda even during that stage. Have we done anything wrong? Can you do something more? So those kind of things will they'll be emoting all these things. And we could also see that emotional withdrawal. The mother who was always with the child in the IP wards, she'll mostly come outside. She doesn't want to be with the child. She will distance herself from the child as her protective mechanism. And also, there will be like, she will not be able to sleep properly. Whoever is providing care, there will be constant waking up in between, just awake throughout the day. And they will also, I have seen personally the parents not letting the child sleep with the fear of whether the child might pass on during the sleep. They'll be constantly waking them up. So this kind of hyper vigilance and these behavioral behaviors, as I told you, there'll be a lot of bargaining. So there'll be some people will be so rationalizing and preparing for things that are to happen after that. So these are the time that as PHO, that the oncologist has to be aware that it is okay for them to do the things that they are doing now. How do you start that statement? I have seen certain parents who are in similar situation do such things. It is absolutely normal for you to be the way that you are doing, and encourage them to express their doubts, fears, and guilt that they have. So I have even seen, and I'm sure all of you must have also seen, jealous among patient. Why is the other child in the other bed is recovering fast, but my child hasn't recovered? So this emotions are absolutely normal for a parent to have. And I have seen parent coming and telling that I feel so embarrassed that I'm feeling jealous for the child who's recovering. Am I a good person? Is this going to make my child worse? So these are all the emotions that we can never be in their shoes, and we have to create a space for them to express whatever emotions that they are going through. So don't be judgmental, just let them tell whatever they feel like telling. And this is the time that we have to use. There are a lot of anticipatory grief tools that we can administer. There are a couple of questions whether they have support in the family system to help them. Are they taking enough self care? So, a couple of questions that we may ask them to identify how they are going to cope up with the loss which is going to be which is ahead now. Okay, so when certain families prepare for the next stage, don't get into being judgmental, saying that okay, their family has accepted totally, and okay, it is okay now. So no family will accept the death of the child immediately. Just that it is a kind of a coping mechanism for them. Whatever they do, just be there for them. Just reassurance need to be provided at every stage. As I told you, siblings are the hidden patients, and often we have to include them in the conversation. We tell them, the parents, to bring the child, the sibling, to the hospital, so that they will know what is happening. Even if they don't know clearly what is happening, in Indian construct, they are often protected from any kind of emotion, any kind of information. They are often considered to just take care of their physiological things like food, clothing, and shelter, and live amongst friends, family, grandparents' house, and they are not allowed to know anything about the disease of the sibling, where they will be dying to know all their things that are happening. We sincerely advise, encourage you as well as the parents to give age appropriate communication. if the child can understand in certain terminologies, we explain them in a way that they can understand. Include them in all the conversation, all the updates need to be provided. Even during death, in our culture, we send them away to some other place. But as we know, palliative care, and also we have to have a holistic family centered approach. We have to inform them and allow them to see their sibling after the death so that they'll get a closure. So otherwise, these might evolve as a psychiatric or psychological complications in the future. So it is very, very essential that we have to include them. What are all the symptoms that the sibling might have after the death of the child or even before the death of the child? There will be constant complaining, somatic complaining, any kind of generalized complaints that the child might have. This can be considered for two reasons. Before it may be for attention seeking, or just they are resembling or mirroring the deceased child. Next one is the survival guilt. So my sibling had passed away. Why should I be alive? She should be enjoying, or he should be enjoying all that I'm enjoying right now. So those kind of guilt will be there. School neglect will be there. Clinging behavior. So these are all some of the reactions that parents might see, but they don't understand that this may be due to the child's or the siblings' loss. When you come across any such behavior, you encourage them to bring the child sibling to the ward and explain them, include them in all the conversations. Is what a small uh, patient case I'll tell here right now. I had a sibling who often comes to the ward, sits and go. One day I asked her, what is she doing? She showed me a small drawing which did not have a lower limb of her sibling. When asked why is she all the drawings did not show the sibling's leg. It was always covered. When inquired, why are you not only drawing the upper body of your sister? Why are you not drawing the full body? She was saying that I'm scared. They are talking about amputating the leg of my sister. I don't know whether they are going to do. Whether I don't know whether it's going to be there or not. I don't know whether she can play with me like before. So nobody, I don't know this information. So I keep drawing like this as a coping. So it is absolutely very, very pathetic that here we don't include the sibling is the have copy the majority of the child's life, isn't it? So that they have to be included in all the conversations. Next one is yeah. This I'll quickly walk you through what are all the frameworks that we generally use in the grief. One, you know, the DABDA, denial, anger, bargaining, depression, and acceptance. As you know, this is not a linear process. People will go back and forth in this. And dual process model is simply, it's a very, very popular model because we grieve at the same time we go back to normal life. We go to work at the same time, get reminded of the child when we see her things or his things, the food, when we eat the food or cook the food that they like, and again go back to the normal life. So that's an oscillating process. And tasks of mourning. So warden's tasks of mourning also very similar to that. We miss the deceased one, at the same time try to go forward, at the same time we won't forget the person behind, but start a new normal without that person. Bowles-by attachment theory is like we there's an attachment style, isn't it? Secured attachment, avoidant, ambivalent during our childhood. The same will be replicated when in the grief period also. I think all these things you can will be covering in your advanced course. So let me quickly go to the next thing. Red flags. This is very, very essential as pediatric oncologist to know from what is normal grief, what is a prolonged grief. This is a quick checklist of understanding what are all the red flags. Okay. So this is something like, as you see, the image is like upgrading to Adobe Photoshop or Plan, something like that. But no, we need to provide support to the family who has lost the child at every stage. As someone said, during death, yes, during death, before death, after 1 month, after 3 months, after 6 months, 1 year, and even more than that. Because all these things, every time we don't know, as we know, the grief and the bereavement is not a fixed schedule. It can happen. For few, it will be immediate after 1 or 2 months, they'll be all right. For some, they will get into a more, they need more period of bereavement. So, how do you identify that? So, once the child is lost, it makes they have to be in a they have to find new meaning to their life. So they will be in a shock. There will be a lot of emotions that are playing. They will not be able to go to work. They'll not be able to cook. They'll not be able to take care of their siblings. There'll be emotional numbness. So when this becomes red flag, when they are not able to do any basic self care, not taking bath, not eating, not cooking, neglecting the other child, totally not going for work. So these are the things which are called as functional impairment, which are happens for more than 6 months, and they are isolating themselves. They are not talking or getting help from any of the other family members. There is an intense emotions, not able to sleep. So these are all the things that we need to check with the family, and these are all marked as prolonged grief disorder, which is there in the DSM-5 criteria. So quick red flags that we can see. Apart from that, there is any expression of suicidal ideation, then they immediately need to be referred to a psychiatrist. So we don't need to wait or do a reassessment, nothing like that. Immediately they should be referred to a psychiatrist. This is very, very important to be noted. So we provide adequate immediate care to them. So another, they are still in shock and disbelief even after 1 year, functional impairment and isolation and anger and suicidal ideation. So these are the things that you yourself can do. It hardly take 2 minutes. Whether are you eating well? Are you going back to work? Are you taking care of the another child? Did you sleep well last night? How are you feeling now? So these are all simple questions that we can ask in our busy OPD. Yeah. So as I already told you, in a busy PHO clinic, you don't need to do a full psychiatric intake. Just do a quick assessment on the support system that they have. What is their coping? So these are the simple things that you can always ask. If they say that I don't do anything, I just simply sit, I don't watch TV, which I used to watch before, I'm not looking at the mobile. So these are all, they're not doing things that they used to do before. So these are all red flags. Some of the tools, anticipatory grief tools, prolonged grief 13 screening tool, suicidal ideations. And apart from all these, we have our clinical judgment, isn't it? So from the experience, we can quickly see that what kind of an impact the loss of the child has had on them. So this is quickly, we'll have a case discussion. Okay. So I think Vinila and Dr. Arjun is there. Arjun are there. We'll quickly go through the case, and all I want is participants to post whether it is the questions that we are having here. A father of a 8-year-old child, the son died of AML 6 months ago, and the medical. The father calls and says that the child has passed on because of the medical team's negligence. He is very, very angry, upset, shouting, and they want to file a complaint and demanding to talk to the dean of the head of the department. This is the timeline is 6 months after the death, father AML. So what do you think, like this is a normal grief or a complicated grief? Is it a normal grief or a complicated grief? You think it's a complicated grief? Okay. Complicated grief. Okay, all of you think it's a complicated grief. Fine. So you think it's a complicated grief because it is after 6 months. Still, he is having some emotions. What do you do? Okay, fine. I get majority of you saying complicated grief. So what exactly do you say to this particular father? Because he's angry. He want to go for a medical legal case. He's already creating a ruckus in the OPD. He's upset and disappointed. So is there anything that we as a oncologist do we do? What do we do? Do you refer this father to somebody else, or you monitor, you manage it yourself, or as he demands, are you going to take him to your head of the department? So what do you do? Any further answers? Anything that you want to share about for question number 2 and 3? So, as I told you, no, there is a chat answer in the chat question. Yeah, make him sit and listen to him. Ask him to write down the problems. Yes, try to have a conversation. True, true. Very nice. Yes. So the thing is, when he is angry and he's saying that it is because of the negligence of the child, truly he's still not accepted. He's calling over phone. First, active listening. Mm-hmm. Okay. Call him to meet in person. Yeah. Sure. So, as we already discussed, this denial, anger, bargaining, depression, and acceptance doesn't go linearly. So, immediately he would have accepted, and now slowly things are sinking in. Thanks for all your answers. And now he's angry. He's in that angry stage, and he's not processing anyway in a linear stage. It can happen back and forth. So, as you all said that you don't become defensive, he's just processing the grief. He's angry, he don't know whom to talk to, so he's talking to, at least he's talking to somebody and venting his emotions. So one should be happy about it, and view, as somebody said, we can call him and give him an appointment and ask him to come and talk. If he is in the same city, we can arrange for home care. We all of the departments will have home care, palliative care departments. So, validate his emotions and allow him to vent all his emotions. That is typically something we can all do to vent his emotions. And these are all some of the validating statements one can say. I can see how much pain you are in. I can see what you are going through right now. I don't, it is very, very loss. Who can accept the loss of a child? I know how much you loved your son. So these are all the things, validating emotions that can make them become less angry and understand. From whatever I have seen, this anger will totally change and they will start crying. So that disappointment and being upset, that is manifesting as anger. Maybe we can use an empathetic, absolutely. All you need is empathetic statements, normalizing, validating, acknowledging their emotions. They are not finding fault with you, they are not upset with you, they are, though they say in those terms, it's not that. Just be allowing them to vent will be a, right now it is not a, you don't need to refer them to anybody because we don't have enough answers. You have to have a more kind of a discussion with him to know who's with him. Is he alone? Is he getting back to work? He has another children to take care of. Who is supporting him? Has he resorted to any maladaptive coping like alcoholic behavior? Is he having suicidal intent? These are all some of the questions we need to ask after meeting him. This information is not enough, definitely, to show whether it's a risk or whether he has to be referred to somebody else. And of course, it's a normal grief. So, though the time frame is 6 months, each grief journey has a different timeline. Unless we identify the risk factor, we cannot classify it as complicated grief just with this timeline and with this information. Okay, next case is a 2-year-old daughter. Arjun and Vinila, do you want to add something?
No, ma'am. Dr. Arjun, you want to chip in?
Yeah.
No, ma'am. I think everything has been covered actually.
Yeah.
Sure. If there is anything, you can always unmute and say, okay. Yeah. We'll go to the second case. This is, I have seen this case. 2 years after the daughter's death, the mother has just kept the room as such. We came to know because the patient is in Chennai, the family is in Chennai, and during a routine call and routine visit, we identified that she hasn't even touched the room. She'll routinely clean it, keep it the way it is. She hasn't gone back to work. She's totally isolated herself from the outside circle because she doesn't want to see others at all, because the other children of the daughter's age are growing up. They are going through the milestones, but she doesn't have anything to share with anybody. So she has isolated totally from anybody. She has all the emotions like anger. The child was born after so many years. Why did the God give me the child and take away? I have this guilty, why I haven't taken care of her enough. Next one is I'm jealous of everybody around me. This is 2 years post death and neuroblastoma. Is it a prolonged grief? How do you validate her love with then next, whether referrals are necessary? So what do you think about this case? Now the timeline is not 6 months, it's 2 years post death. Do you want to suggest anything? Now I have given enough information about what a complicated grief should look like, and what kind of grief the parents must be going through, and based on their activities, what do you think this is? Is it a complicated grief? Prolonged grief and refer to psychiatry. Yes. Thanks, Shruti, for that. Prolonged and complicated grief. Okay. Sure. So how do you validate her love? So she's doing it for a reason. So how what do you tell to her? So it's absolutely absurd that you are doing it. The house should not be like that. So how do you, again, empathetic statements come handy. Okay. So you see the love that she has for her daughter. She has a intense feeling that she's still living there. Sometimes she used to wear the dress of the child when she cannot sleep. So these are all the things that the mother is doing. So you have to validate, saying that this is because of her intense love that she has for the child. So you say some statements that are validating her emotions, and also do the screening before you refer to the psychiatry. Absolutely, we need to refer to her psychiatry because we see that she's isolating herself. She's not having any coping mechanism. There are a lot of red flags in that. So yeah, absolutely. We also remember the way that is fantastic. Yeah, that is a very, very powerful statement that we can tell the family. We too remember the child in the same way that you remember, right? Yeah. This is another case. A 10-year-old sibling, younger sibling died of ALL, and the other sibling is refusing to go to the school. He is becoming clingy and somatic. As we already saw, these are all the symptoms that a sibling will have after the sibling passes away. This may be typically, and maybe use another statement asking her to, it may be so difficult to deal with the loss of a child all alone. We all feel same. Absolutely. Right. Right. Yes. We are all with you on this. And we can also suggest them or encourage them for a couple of coping mechanism. Absolutely, we have to refer them to psychiatrist, and after that we can connect them with peer group. So parents who had lost their child, that peer support group also we can allow her or introduce her to such families, because no matter in how many words we say that we can understand, we are not allowed to say we can understand, we can empathize, we can only do it to a certain limit. The peer support will do a lot of they will share the best practices, they will tell how they had come across their grief, they are not alone in this grief journey. Those kind of things will help them. So coming back to this sibling school refusal case, this is because the child has not been constantly involved in the or updated about the siblings health conditions, that is manifesting in different ways, as like a survival symptom is there, not going to school and all those things. So certainly, do you refer them to the psychologist at what point? Again, too early referrals will only too much of clinical diagnosis are not going to help the child. It is not only going to attach stigma to the child. So we have to just understand that, explain the parents basically. Explain the parents basically, but because this is happening due to this particular reasons, and tell them that the child has passed on, the sibling is going through the grief in the same way that you are going through. Constantly monitor the child, and after assessing them through a prolonged grief tool, we can refer them to a psychologist or a psychiatrist in the next session. So very, very important is, now we know few red flags we have to identify, whether they have proper social support, whether they are going back to their work. If they are not female and not having work, they have to do their responsibilities that they do before. Siblings taking care of them, having some kind of coping. If this suicidal ideation, these are all some of the red flags we have to check. If they are not there, then refer them to appropriate psychiatrist or psychologist. So when do we do this bereavement follow-up? So it is very, very important because in our busy OP, we tend to forget. We treat the child actively. Once the child passes on, we don't have that kind of priority to reach out to the family because we have other commitments to do. So this is often neglected, but this is very, very essential in terms of this will prevent another child or another family getting into a complicated grief. So this cost is also very, very essential because once it is getting into a very complex psychiatric conditions, then it is going to be very, very difficult to recover. So bereavement follow-up and early identification of red flags is very, very essential. This is from a paper like when we do a regular follow-up, actually immediately after death, contacting them, asking whether they need any support with respect to the death certificate or commuting or arranging for ambulance, those kind of. Then later we'll call. I'll explain about that later. But only 10. All the support, every family need to be made the standard bereavement call. Okay, so and about 30 percentage of them, so 100%, this is 100 percentage of them need to be called immediately after death. That has to be provided to all the families. When we identify that some risk factors are there, like there is no extended family support, there is already some kind of mental illness in the family dynamics is not so great, it is a single parent, they have a traumatic experience with the hospital and death of the child, so they need to be contacted frequently. That is approximately 30 percentage of the families, that kind of support is needed. After though they are a single parent, though they don't have an extended family, though they have a traumatic experience, if they are coping well due to with this, a lot of other things that they have, then they don't need further support. Only few, about 5 to 10% only will get into very complicated grief who are not, who needs appropriate referral. So this is the bereavement support model. So we need to make a call to all the families and shortlist them based on the risk factors and follow up. We dismiss some of the families we are not into complicated grief and provide care only to small portion. So this itself shows that the work is not more. A dedicated team of 2 to 3 people can do this follow up calls. That is what we are doing in our setup for bereavement support. That is the standard of care that we provide as a palliative care department. Yeah, immediately after death, we need to call. This is a timeline that you all of you can just note it down in your thing and use it. So they should not feel isolated and totally abandoned by the treating team. Hence, we need to make, yeah, the department sends letter every year expressing our yeah. Yes, Shruti, like this is again, I have done a detailed research about bereavement support in our setup and administered a need assessment survey for bereavement. Most of the families in our setup, especially they are from lower socioeconomic status, they don't want to be in connection with the hospital, some of them. And some of them don't want to be remembering the child on the death day. So it is very, very specific. So we need to understand our families better. And if possible, you can administer this need assessment survey and see what the families need, and appropriately we can provide the support. So yeah, that is one suggestion that came from the parents. You give us what we need, not that you think we need. That was a very powerful message. I wasn't sure of the impact. Yeah. Absolutely, absolutely. We try all these things and we learn from what we do, isn't it? Yeah. The idea to provide support itself is a great thing. Immediately after death, we need to call them, understand whether they need any support, practical support, understand that they are undergoing a great loss. So those things. And after 1 month, we have to certainly call them whether how are they doing, because now is the stage that all the extended family would have left after the rituals specific to their community or religion. We need to understand what kind of emotions that they are going through. Then call probably after 3 months and identify for red flags, whether they're getting back to work and all those things. Some empathetic messages that we can provide. So I have seen certain families ask that whether I can have another child, whether that child also will have similar disease. Then they will ask whether I want to get tested for my another child for genetic testing. We'll arrange for those kind of things. they need some financial support or psychological support for the sibling or even for the mother. So I had one brother who was not able to go through the loss of the sister. We provided him psychiatric because she was not able to sleep for more than 6 months. So continuing, these are all some of the best practices. And this is something I thought, in one nutshell, I can tell you. You have to be strong is something we cannot say. So we need not be sorry. Sorry for the loss of a child is generally we'll avoid saying. We can only tell as a in a normal setting we can say as a friend or a family member. As a healthcare professional who had provided care for the child, we can say we are sorry that you have to be in a difficult situation like this. We are sorry that you have to go through all these. So those kind of sorry we can say, but not sorry for the loss of a child. The child will not go through any pain anymore. He is in a better place. Now you have another child, so you have to take care of him. These kind of things are like dismissing their emotions. So we should strictly avoid saying all these things. We can always say, as some of you posted here, we also remember the child the way we are here for you. So these are something I can imagine, or I cannot imagine how painful this must be for you. So these are something we can always say. Yeah, as all of you told, listen more than you speak. Okay, normalize their emotions, acknowledge their emotions, validate their emotions. These three will do miracles. So you yourself can become a therapist when you say this. Yeah, when they say some statements, allow them to tell more about it and respect for what they have shared. We can tell that I have huge respect for you because you have come back and told us all these things. Not many can do that. You're talking about your child. That itself shows your courage. Few families will avoid using the name of the child. Few people will not even talk about the child name, but we can remember and say, we can remember the child's name. All of us in the department remember Serena. All of us remember how brave the Bhuvanesh, the child was. So these kind of things we can use. Yeah, grief is very, very, very exhausting, physically, mentally. So offer them if they want any practical support. That is something we all of us can do. Yeah. So this is one of the bereaved parent. We are doing a home care and providing a bereavement counseling. So just help them to go along with their life without being feeling a sense of abandonment. Okay, so we tell them it is okay for you to think about your child. It is okay for you to cry for your child. It is okay to remember about the child when you cook his favorite food. So these things are okay. You cannot cut everything, cut ties with the child, but the deceased. At the same time, you continue with your life. So this is something which the goal is not to help them get over it, but to help them integrate the loss into their life while preventing the feelings of abandonment. Okay. So, yeah. This is something that we developed for our institute after doing this bereavement need assessment survey. We have referrals from all these departments. We have our bereavement support team as pediatric oncologist, palliative care physician, psycho-oncologist, palliative care psychologist, medical social worker, volunteers. So immediate before the death of the child itself, we built a rapport with the family. When they are going into terminally ill stage or actively dying stage or hospice shift or they are into supportive care, they come into bereavement support. We do a family counseling, understand how the family dynamics are, what are all the resources, what are all the challenges that they have. So these kind of assessment as psychologists and social worker will do, whether they need practical support if they are outside of the city, whether they need transportation, those kind of info, whether we have to include the sibling. This quick assessment had to be made before death. Once the death happened, follow up in person or phone or SMS has to be happening immediately after the death. After 1 month, we will inform them about if you want anything, we are always there. Share with them the emergency number. Then follow up after 3 months. Till 3 months, we will not do any red flags for them. Okay, after 3 months, we'll identify the red flags. If there are no red flags, do a 6 months follow up, 12-month follow up, and invite them for bereavement support group meeting, which is happening annually, where other bereaved parents are also there. If there are red flags, then after the assessment, we'll plan an intervention, whether we need to introduce them to a psychologist or a local psychologist or a video counseling or psychiatrist, teleconsultations. After that, regular follow-up, and if they have come over it, then regular follow-up. If again some interventions are needed, we will continue the intervention till they are feeling all right. So this is something which we are following in our Adair Cancer Institute. So documentation needs to be there. Okay. So this is needless to say. As I told you, social worker will assess the practical and need, family support that they have. Psychology will and understand the pre-morbid psychiatric illness, how they had coped with the disease and treatment so far, what kind of equations that they have with the hospital and the healthcare management. So we have to know whom we should call, who is the person who is very clued up and can understand and take the family forward. We also give a information kit to the family when they discharge. So all the essentials numbers will be there for them to call in terms of physical symptoms or psychological. We don't put it as psychological symptoms. We'll just put it as, if you need any support like this support, you call this number. If you need these kind of support, call these numbers. So those information kit will be sent to the families as they get discharged or even during the anticipatory grief stage. Now we come to the important point, like your own grief. So you know that as the family grieves, the grief of the oncologist pediatrician, I had a mother who said every time it rains, she could never sleep thinking of how lonely and scared the child would be feeling in the grave. True, true. Very, very sad to read this, isn't it? Yeah, we come across such kind of thing. We have to just respect them for their sharing such kind of deep, very, very intimate emotions with us first. And as I told you, those families should be constantly in touch. They should not feel a sense of abandonment. And we also have to have a conversation of death, dying, and after death kind of conversation. True. So yeah, coming back. Yeah.
Sorry. And in this context, what you are just going to start is very pertinent, which is grief of the oncologist, because sometimes we just end up imbibing all of this. And at what level it affects us, I think many of us do not realize, because it spills over to family life, it spills over to kids. Sometimes these emotions, when she said that, I really did not know what to respond for a minute, because it's so true. I mean, being a mother, it's really a hard feeling. And to even tell her, get over it, I'm not even sure if it's right for us to say. It's a
No.
very complicated situation.
Yeah. Absolutely. Thank you, Arti, for sharing this. So, some of these questions that parents say, that we hear, we are so helpless. I understand that. And we immediately get into a problem solving mode. That is what we always think, isn't it? Have to do something and solve the problem. This is not a problem to be solved. Okay. So she is not going to not feel sorry for whatever you are going to say now. And some of these questions or some of these statements don't need any answers. So all they want to do is just share their emotions and how they feel with you. So you have to be there for them. That is the something that you have to constantly exhibit. And none of the skills that we have or show is going to compensate the sadness or the loss that they had gone through. So just be there for them. And as pediatric oncologist, you do everything for the child. And I personally know oncologists who cry and have been gone to the funeral of the child when the child passes away. And I have had oncologists fight with the palliative care team because the child is dying, you are not providing enough care to the child. So they all know about the clinical details of the child and the condition of the child and the prognosis of the child. They are not able to accept it. And I have also seen oncologists not referring the child for supportive care because they consider it as a personal failure, handing the child over to the supportive care. So these are so many emotions that we have come across, and the grief of you is no less than the grief of the parents and the family. And of course, you cannot handle as Arti shared, you cannot get back to your normal life and enjoy your life or get back to your children when you have lot of such emotions. So you cannot pour from empty cup. We'll see what we can do in a minimal way that to handle the. Now, anyone, as one of you shared me, think of one patient. You need not even share with me whose loss, there will be a lot of patients that you see, which loss that stayed with you. You don't have to share, just hold them in your mind. Just think about the child that you're not able to. I cried the day that the mother told me that named a newborn after me. My guilt of not being able to child this son became worse than. Yeah, as the parents say that they feel guilty for not having done enough for the child, same as the feeling of the oncologist too. We always have the feeling of not having done enough for the child, but by all means, you would have done all that you can and beyond what you can. Okay, so what did you feel when you think of a patient who was lost despite the treatment that you provide? What was the feeling that you went through? What would support have looked like then? Yeah. What kind of a support that you would have? Yeah, you had gone through many. What kind of a support that you would have needed then? Is just something for you to think about. We'll talk about it. Lot of compassion fatigue in oncology, especially pediatrics, especially compassionate fatigue. So repeatedly witnessing somebody suffering, leave alone death, constantly seeing them suffering. And when you see child of the same age in the normal life and you see the child in the ward, so it is very, very difficult. So have I done enough? This is the same thing that the parent have. This is the same thing that the oncologists also have. So when they get back to the normal life after the loss of a child, it is not easy for them. This is a bereavement support program where pediatric oncologists are talking to the parents, expressing their own guilt. They're sharing. As the parents express the guilt, the pediatric oncologist also tell them what they went through after the loss of the child. This was a kind of a healing for them, not having any defenses, just opening up as a human to human. So this is a bereavement support program which help both the families and also the pediatric oncologists. And also there is a not much of a talking or debriefing happens among clinicians, isn't it? An open talk about what they did, what they could not do, what went wrong. Sometimes we cannot do anything. So these kind of conversation has to be happening very, very frequently within your department. But there will be lot of silence, isn't it? The clinicians are not supposed to cry in front, and they are not. They are supposed to be strong and all those things. They are all defensive. So these kind of things adds on to your fatigue and burnout. So as I told you, pediatric oncologists express grief reactions similar to parents, but they are rarely given permission to grieve, or they are never given a safe space to do so within the medical system. Do you personally or honestly think and say whether you have enough time to talk about the child within your hospital setting or a department? What went wrong? What went right? It is more for the society, I guess. I hope parents go into, yeah, of course, that is what exactly I'm saying. Like how a father is expected to be stoic, even the clinicians are expected to be stoic. So this is something we can always do. So interdisciplinary forum where we can discuss about the emotional and social aspects, debrief and reflect. This is something we did do in this is a psycho-oncologist, medical oncologist, palliative care, when we are discussing about a bereavement support program and the loss of the child. One oncologist, pediatric oncologist, told that every Diwali he'll get a message from a parent of a child who passed away, cursing him when we are all in dark, you guys are celebrating Diwali. So initially the doctor thought that let me block the message, but then later thought this is the only avenue where he's expressing his emotion, whether it is anger or whatever. If I close that avenue, I don't know what will happen to him. So I continue to reply him. When you think of the child, we also think of your child whenever we celebrate. So as I told you, the being pediatric oncologist is not so easy. Debriefing in a safe space, sharing what ethically, morally, what went wrong or what they did, what they feel. So post death hurdles, that is very, very important. As I told you, immediately call the family after the death of the child. It is important that we as a treating team also connect amongst ourselves and discuss amongst ourselves, so that it is we share with each other and normalize the emotion that we all go through as treating physicians. And finally, certain things I always say whenever I take a class, when we see that we are inadequate handling anything, we upgrade ourselves. So when we think that we don't have enough words to talk to a family after a death of a child, we upskill, attend classes like this, understand what are all the phrases that we can say to the family, what are the things that we should not say. So upskill ourselves. Next one is have a structured supervision and have a mentorship with somebody who's good at it. And also we need to have a professional boundary. Otherwise, we are not going to be able to pour from an empty glass. And seeking help is a strength and a professional duty. It is not like it's a failure or you don't think that you are inadequate. When you seek help from anybody, it is always better. We can work as a team. It's not your personal responsibility to provide care for a child because it's a professional duty that you are doing. So I have come to the final stage of this grief and bereavement session. And before that we close, I will just say that these are all the key points that you have to think about. Grief is normal. Grief doesn't have a timeline. Like 3 months, you have to be okay. 6 months is too much. You have to be okay by now. Nothing like that. They can take their own time. We are there to be there for them, support them in whatever way the family is grieving. And we should not go for quick fix or go and get into a problem solving mode. Now, second very important thing is early identify anticipatory grief. From the anticipatory grief, we have to have a rapport. If you don't have time, connect them with essential psychologist or social worker who can handle the family. Then oncologists are never standalone oncologists, isn't it? You are also a psycho-oncologist because you also deal with lot of emotions of the family. So you early identify, appropriately referral to your team member, multidisciplinary team member. Follow-up is very essential. Otherwise, they will feel a sense of abandonment. There will be inner culture, enough proper support is not provided by the family. Of course, they provide lot of support, but in a different way. We only know the red flags, appropriate referral and all those things. So we need to do a 48 hours, 1 month, 3 months, 6 months and 1 year follow-up. I can also share the documents that we have prepared. What are all the stock phrases that they have to say when they call during every calls? What are the timelines of call? So those things I can share with you to Inila, and you can also use it if you think it is appropriate. Identify red flags, as I told you: social functional impairment, isolation, lack of social support, not getting suicidal ideations. So very sensitive conversation, as we all told. Avoid things that we are not supposed to say. Acknowledge, validate, normalize their emotions. Some empathetic statements. So this I already told you, isn't it? Like grief is not something we treat. It is something we witness, support, and walk beside. Like before grief, we had treated them. That is treatment. But when the death has happened, it is not something that we have to treat. We have to just be there for them. We cannot solve the problem. No matter 10 years or 20 years, the grief is going to be the same for them. No amount of support that we provide is going to make up for the loss that they are going through. So all we can do is be there for them. We have done all that we can. This has happened. We can only support them. Thank you. I'm open for any questions or anything that you want to share or anything you think that one adolescent girl's mother mentioned that she wants me to be born as her son. How do we respond here? You just need not respond. Just smile. That shows how much love you have for me. That's all. Just a non-verbal action, a nodding, something like that. Even when they say you are God, so even those times we'll just nod their head, smile. Just acknowledge that because they are saying that kind of a statement because they have a huge respect and love for you. No, it is not a place for you to judge what it is a sarcasm. It's just a statement. It's a space that they are venting out their emotions. We are not in a place for judging whether it is a criticism or right or wrong. They are going through a roller coaster of emotions, and that is one of the statement that they say. Most of the time they don't know what they are saying. So we are in authoritative position. They are in a receiving position. Most of the time they say something and we just listen. So that's it from my side. If you have anything to share or post or discuss, you can always post it here. And any of you want to unmute and share about a case that you want to share? Like I had asked about, think of one patient loss that stayed with you till now. So we have about 35 plus participants. Any one or two of you can tell and talk. Is there a situation where you found very, very difficult to handle? Uh, is there anything you can always say? Can say this means your daughter means a lot to you. We also wish the same for you and be with them, right? There is always like no one way of handling a thing, isn't it? All right. I think Dr. Raman had logged in and he said that he wanted to tell something. So do you want to do that now before somebody? Yeah.
Raman sir, good evening.
Hi, good evening. Can you hear me?
Yeah, yes, sir. Over to you, sir. Please. You can address
Thank you so much. I'm sorry I'm coming in the middle of such a wonderful talk. I was mesmerized by the way Vinuta spoke, and it was my good fortune that I logged in for. This is the only session I've attended. And if this is the standard of what was being done for the last 9 weeks, then I'm very glad that this workshop has been conducted, and there's so much good things which all of us have learned. And hope that there are many more batches after this. So I just wanted to acknowledge Gayatri and Veronique and Archana, who have really taken the lead on this. And ICC has played a very small role in making this happen. But thank you to them and all the faculty who've been conducting this course. Also, it is really a great thing that we could convert this into a partnership with PHU IAP so that PHU IAP can offer this as a course, not only this time, but subsequently also. And PHU IAP is the right custodian for delivering training to pediatric oncologists. We have many more ideas and ambitions. We want to extend this to nurses. We want to extend this to others. So we'll see how this goes. But thank you very much to all of you for giving ICCI a chance to be part of this. And any suggestions are very welcome. You can contact me directly or you can contact Gayatri or Veronica or Archana. Thank you so much.
Thank you, sir, for your wonderful words. Now the platform is open to the candidates for any further questions.
I see some messages in the chat. I'll read that. Thank you. Okay. Success. Okay. Okay. So if there is nothing more to share, I'm sure Vinila would have shared the pre-test and post-test, isn't it, Vinila?
Yeah.
Both.
Yeah. So what I'll do is now I'll request Nandini, my colleague, to kindly post the post-test and feedback link in the chat box and also as well as in the WhatsApp group. Yeah. So I really want to thank Vinita ma'am.
1 minute, Vanilla. Like if you anybody has any doubt or any ways of how to conduct support group on bereavement or grief, anything, you can always reach out to Vanilla. She will share you my contact number and mail ID. If anything that is required from my end, I'll be more than happy to share with you. Thank you. Thank you for being so participative, some of you. I hope all of you had gained something from today's session. Thanks. Yeah, over to you, Neela.
Thank you, ma'am. Absolutely. That was really, as Ramandeep sir also mentioned, that was really a great session. And I agree with you. So I want everyone to please kindly fill your post-test and also feedback link. And I know that we have come to end of this the series of virtual training in children palliative care, which we have been doing with ICC and PHO chapter and in collaboration with Hyderabad Center for Palliative Care. I really want to thank the entire faculty who have taken the lead, as Ramandeep sir has mentioned. So many people have worked so hard to make this and make it into 9 sessions, and we have your attendance also ready with us. I think within 2 weeks time we'll try to analyze the attendance, and also we'll post like how is that your self evaluation or self reflection is going to look like. So are we going to have an examination online or things like that? We will discuss internally with the task force team and we'll get back to you. Thank you so much. And Vinita ma'am, that was really wonderful. Thank you. Thanks to each one of you, and thank you, Nandini, who have been silently doing all this coordination work from the background. Thank you.
Yeah, thank you so much. I'm logging off. Thanks.
Ma'am, is there any announcement regarding the advanced course, or is it likely to be made anytime soon?
Yeah, the task force committee is working on that, ma'am. I think we'll get back to all the candidates with the self-reflection and evaluation part of it, online exam part of it, and also we'll post your attendance results so that like if you missed anything, so that everything is perfect. And also like when are we going to plan this advanced course, we'll post it in the group, ma'am, in the WhatsApp group.
Thank you. Thank you so much, ma'am.
Thank you.